All right, everyone, welcome back. So, for this one, talk about the secondary assessment, particularly EMT basic assessment. So, for the EMTs that are EMTs in training, for those of you that are learning to go for EMT, we're really going to stop with the assessment here. And this will be an introduction to the secondary assessment for advanced EMT. So, if you want to learn more about more in depth secondary assessment techniques, certainly go on to the next videos in this series and feel free to expand your knowledge. But for this lecture, we're really going to just hit the overview and the approach to secondary assessment, and we'll talk about some individual assessment techniques in the lab. So your secondary assessment, again, remember that your assessment is driven by your trauma patient. It's what you see is what you get. So it's a physical, head to toe, hands-on assessment, exposing the patient, looking, listening, feeling. But for your medical patients, it's important that your secondary assessment, just like the history taking and the vital signs, all should occur after your primary impression and vision. Okay? This is done after you've decided if the patient is a load and go. A load and go patient, you're doing the hospital, or if it's a stay and play patient, you may be doing on scene. Your secondary assessment is driven by the history. This is particularly important with medical. And really important thing to understand. A poor history is going to lead to poor assessment because the history drives your assessment. Your goal with the assessment is to find more objective information. We're talking quantitative information, things that can be measured, okay? Things that can be felt or things that are felt by the patient. That's your history part. That's your subjective. For more objective information. And don't forget to make sure that you ask in your history taking about. All right, let's talk about the head to toe. So this is in a patient. They may be having a medical event. They may have had a traumatic event, but it's in the unconscious patient where you have no ability to get any historical information. So you're really going to try hard to find visual clues, make sure that you have assessed your patient. Okay. So first things first, remember that assessment, you have to be able to look, listen, and feel, and you can't assess what you can't see. Okay. You're going to use a systematic approach for the patient. You're going to expose the patient when necessary, but always try and maintain modesty. For your trauma patients, particularly if you're in a place, try your best to maintain. Sometimes it's not the most prudent to expose a patient in the middle of a street. Maybe you can move them to the back of the truck before. So remember, this is done after your primaries. Make sure there's no life threats, but we're going to expose the patient and take a look and see what we can find here. See if we can look, listen, and feel. So you're going to start at the head of the patient and you look at the face. And you're going to look for symmetry within the face. So that there's things like unequal pupils. Your pupils and make sure they're not up. Look at the nares of the nose. Make sure it's not blood or vomitus or something. You can look at the ears. Make sure there's no seepage from the ears or fluid, blood, etc. Look at the neck. You're going to look for things like jugular venous distension, the neck veins. Evaluate the trachea, middle, midline, okay, or is it shifted from one side to another? You come down to the chest and you're going to palpate the chest, and that means you're going to take your hands and place it on the chest. You should have already done this with chest rise and fall for respiratory. You should be putting your hand on the side to avoid breast tissue. Hands on the side and feel chest expansion. But you're going to palpate, push on the sides of the chest and see if the chest wall is intact. Do you feel things? And this is where we go back to the DCAP BTLS, right? Do you feel any deformities, contusions, abrasions, punctures? You're going to make sure you auscultate. Listen to. Come down to the abdomen. You're going to look for bruising. Things like periumbilical bruising, bruising around the umbilicus, belly button here. And auscultate the abdomen. the bell side of your stethoscope, you can vowel sounds. Then you can palpate. You want to make sure that you auscultate before you palpate, because once you push on the belly, the gastric motility changes. You want to evaluate hips. Are the hips packed? You have femoral pulses. Pulse point right here, artery pulses. Moving down the legs, making you don't have any bruises or abrasions on the knees. Can you articulate the joints? Come down and feel for the popliteal pulses. Okay, make sure you've got pulses, distal pulse, feet. Check your pulse motor and sensation, right? Make sure you've got good distal circulation. Come up here to the arms, the same thing. You can articulate the joints. Come down and check radial pulses. Check your capillary feel, fingers. Okay, all things that we're going to look for that medical. Focused trauma assessment is going to be based on your head to toe assessment. However, this is usually for a conscious patient who has a specific area of complaint. So while we were talking about full head to toe assessment in the unconscious patient, your focused trauma assessment have arrived on scene and someone has suffered a laceration to their right arm. You don't need to expose the full patient and check femoral pulses, popliteal pulses, and pedal pulses in that patient necessarily, and focus on the area of complaint. You still need to expose that area, and you need to assess that each of the systems in that area are working appropriately. So if you've got an injury to the arm, you want to make sure that the musculoskeletal system is intact. Does it feel stable, right? Do the bones feel stable? Joints able to articulate? Is the patient able to move and flex their joints? Has hemorrhage controlled been in place, or has hemorrhage stopped? Okay, those are things that are. So remember too that trauma patients can also have medical problems, also have trauma related issues. Okay, so don't get tunnel vision. Sure that you are focusing on all areas. All right, let's talk about the last type of assessment, which is focused medical assessment. Now, the focused medical assessment, I like to try and encourage folks to use a bullseye approach. What do I mean by, well, based on your history and based on the patient presentation, we're going to look at the most likely affected organ system. Let's say that our patient to chief complaint of chest pain. Most likely organ system are going to be chest pain, cardiovascular system. So we're going to start our focused medical assessment. Vascular system. We're going to check distal pulses in all areas, right? We're going to check and make sure radial pulse matches the right radial pulse. We're going to look at their blood pressure and make sure that they have adequate perfusion, capillary refill. We may ask about relevant, pertinent history, patient presentation. Look like they have a deteriorating cardiovascular system. Take medications for heart disease, heart problems. Once we fully assess the cardiovascular system, okay, we're then going to move to the next most system. Well, with cardiovascular, next most intact would be the pulmonary. Try and draw rudimentary for you. Okay. So we would then move out of the cardiovascular system and assess the pulmonary system. Okay. So we may do things like listen. Is the pain that they're feeling in their chest related to being short of breath or asthmatic? Okay. Having a productive cough? Okay. Do they have a temperature, fever? That would be another cause or problem we would look at. Okay, so we start with that narrow cardiovascular, then we move to the pulmonary system, and then the next system we may be the musculoskeletal system, right? So maybe we're concerned that the patient has pulled muscles or in their chest, or they've sustained some impact trauma to the chest that's causing chest wall. So we may then palpate around the chest. Does it hurt when I push? Okay. Does it hurt when you take a deep breath? Did you recently sustain any injury? Those are the next most likely pieces. And so, with your focused medical assessment, you really want to drill down to the most likely and then expand your search until you find that, right? Turns out the guy has chest pain, also has deep pain on inspiration, has some crackly sounds in lungs when we listen to lung sounds. And when I push on the sidewall of his chest, he's really sensitive and sore. I feel crepitus or grinding. Okay. That points to less of a cardiac issue and more of a musculoskeletal. So you're going to use that expanding approach with your patient to find what it is. It's likely being that detective, being that diagnostic, okay? Because that's how it's going to drive your treatment. Right? Thank you guys, and